Good afternoon. I just wanted to specify before I start my presentation that in Sophie's presentation, she mentioned the Ebola management centers. In my presentation, I will call them Ebola treatment centers. We are, in fact, talking about the same thing. So today, like I said, I'm going to present data from the follow-up of survivors of Ebola virus disease. This is an ongoing project in Freetown. So as a short background, this slide is to remind us that to date there have been over 26,000 cases of Ebola virus disease, or EVD, from this currently ongoing epidemic that began in Gekedu, Guinea, and that has affected 6 African countries. 2 of these, Guinea and Sierra Leone, unfortunately have ongoing transmission. And in these areas, CFRs range from 50 to 70%, depending on the data source. Now, the first confirmed cases of EVD in Sierra Leone occurred in May 2014, while in Western area, which is where Freetown, the capital of Sierra Leone, is located, the first cases were reported in June 2014. However, the peak of the epidemic, highlighted by the red bar on the x-axis of these epidemic curves, occurred in Sierra Leone on the left and Western area on the right in December 2014. So currently, there have been over 12,700 suspect, probable, and confirmed EVD cases and 3,900 deaths in Sierra Leone. And approximately 30% of these have occurred in Western area. However, in good news, there have also been over 4,000 EVD survivors in Sierra Leone. So these are patients who had a laboratory-confirmed EVD infection, were admitted into an ETC, and subsequently discharged negative. Now, in response to the large number of cases and the limited number of beds available, on December 10, 2014, MSF-OCG opened the Prince of Wales Ebola Treatment Center in Freetown. This was a 100-bed unit, as you can see here in this photo. So in the ETC, psychosocial support was provided to patients and their families during hospitalization. Additional activities included health promotion, household and community disinfections, and support to quarantined households in Western area. And finally, the EVD Survivor Follow-up that I will speak about today began on February 3rd, 2015. Now, prior to this outbreak, no systematic follow-up of EVD survivors after discharge from an ETC had been carried out. Thus, the objective of this follow-up is to provide care and treatment for the clinical and psychological sequelae experienced by EVD survivors after discharge and to document their evolution. And to do this, survivors from MSF ETCs in Sierra Leone were invited to participate in the follow-up program. Their family members were also eligible to participate if they were an EVD survivor, and we could confirm this. So for safety reasons, and in order to ensure that we are only providing care for EVD survivors, if we were unable to confirm their EVD status, they were not included in the follow-up. And finally, in order to schedule visits, all survivors needed to be able to be contacted and present to the clinic for follow-up. And before continuing, I would just like to point out the photo on the slide, which is of the last patient discharged from the MSF-OCG ETC, who is also a survivor. Now, for each follow-up visit, survivors come to the clinic, which is located not far from where the ETC had been. Many activities take place during each follow-up visit. These include a clinical consultation, during which a full physical examination and vision screening is carried out, and during which support for family planning and referrals for specialized care are provided when necessary. Additional activities include psychosocial support and health promotion activities, which include group discussions. Now, initially, visits are scheduled every week. So for survivors who were discharged from the ETC after the follow-up program began, their first visit occurred the day they were discharged from the ETC or the following day. For survivors who were discharged prior to the beginning of follow-up, their first visit was scheduled as soon as we were able to contact them. Now, this project is still ongoing. Consequently, the results of the descriptive analysis I will provide here are preliminary. In addition to presenting estimates for the entire cohort, all results on the next slides will be stratified by ETC of discharge, so either MSF-OCG or other. So a total of 1,009 follow-up visits have been made by the 162 survivors in the program. This is a median of 4 visits per survivor. Of the 83 survivors from MSF, OCG, ETC, 80 have participated in the follow-up, as you can see here. The median time between a survivor's ETC discharge, and their first follow-up visit is 36 days. Overall, 11.1% of all survivors had their first follow-up visit within 6 days after discharge from the ETC. Median CT at admission to the ETC, which is currently available only for MSF-OCG survivors, was 21.2. And to date, 92% of survivors have been discharged from the clinical follow-up. And the number of days between discharge and first follow-up visit, and the number of survivors having their first follow-up visit within 6 days after discharge were significantly different between the two groups. Currently, 46.2% of survivors who have had at least one follow-up visit are female, with a median age of 24 years. 71.6% of survivors are 12 years of age or older. At their first visit, the median body mass index is 20.4, which is approximately normal for adults, and the median number of physical complaints expressed by the survivors at their first visit was 4. So the 5 most frequent symptoms noted by the physician at the first visit are suspect ocular complication, polyarthralgia, anemia, skin disease, and respiratory tract infection. However, we are also seeing a relatively significant proportion of survivors experiencing back pain, hair loss, and suspect cardiac complications. For survivors with suspect ocular or cardiac complications, they were referred to either the eye clinic or the hospital in Freetown for additional follow-up. So for survivors who were followed up at the eye clinic, 95.3% were diagnosed with an ocular problem. These problems frequently require additional follow-up, and in this group, the number of follow-up visits range from approximately 1 to 5 per survivor. And in an attempt to standardize diagnoses, whenever possible, conditions such as uveitis were classified according to the standardization of uveitis nomenclature. So the most commonly diagnosed ocular problem was, in fact, uveitis, which was diagnosed in 58.5% of survivors who received care at the eye clinic. For those who are not familiar, uveitis is the inflammation of the uvea, which consists of the middle pigmented vascular structures of the eye and includes the iris, the ciliary body, and the choroid. The most commonly diagnosed categories of uveitis were anterior and panuveitis. So it is important to note that prognosis is generally good for individuals with uveitis who receive prompt diagnosis and treatment. However, if this is left untreated, serious complications can arise, including cataracts, glaucoma, macular edema, and permanent vision loss. Overall, there were 116 survivors for whom data on mental health consultation was available as I was preparing this presentation. These individuals have had over 477 visits with the mental health team, a median of 3 visits per survivor. At their first visit, 25.4% of these survivors were living in a quarantined household. When looking at indicators of stigma, 25% reported being embarrassed or ashamed of having had EVD, and 25% reported that they felt that others have avoided them because of their EVD infection. And concerning indicators of psychiatric disorders, 1.7% reported hallucinations, and 2.6% reported being irritable or moody. When assessing emotional distress using the 20-item self-report questionnaire, also known as SRQ-20, the median score for the entire cohort was 5, slightly higher in those survivors released from a non-MSF-OCG center. So elements of the SRQ-20 assessment that were significantly different between the two groups at visit 1 are the proportion of survivors feeling unhappy, those feeling nervous, tense, or worried, crying more than usual, and those being easily frightened and having trouble thinking clearly. And so finally, this project is still ongoing. However, we have seen that all survivors released from the MSF, OCG, ETC that have been able to be contacted have come for their follow-up visits. In this survivor cohort, we have seen a high prevalence of uveitis, particularly anterior and panuveitis, conditions with which early identification and treatment, long-term consequences such as blindness can be prevented. And regarding mental health, although the overall SRQ-20 score seems to be low at the first visit, survivors released from other ETCs appear to have a higher level of emotional distress than those who were released from the MSF-OCG ETC. This may be due to the fact that stressors and symptoms of distress may appear later after reintegration when survivors face grief and difficulties in their social and personal lives. And finally, after 3 months of follow-up, over 90% of the survivors have been discharged from the clinical follow-up, demonstrating that with correct and timely management, many of the clinical problems experienced by these survivors soon after discharge are improving. And finally, I would like to acknowledge all of the survivors and everyone in Sierra Leone, Geneva, and Paris who have contributed to this project. Thank you.
Thank you very much.